No.
Great, welcome back everyone to Health Healthcare. We are still talking about H766 and we have Sarah Teachout with us from Blue Cross Blue Shield.
Great, thank you. So I am Sarah Teachout with Blue Cross and Blue Shield of Vermont. I am the Director of Government and Media Relations. So I've been in this committee many times in the past and even talking about prior authorizations previously. I was going to just talk a little bit about what Blue Cross does with prior authorizations. I don't want to go on for too long. I know you've had a lot of testimony. And I know you already heard this, but prior authorization is our way as the insurance company to protect patients, approve treatment based on medical necessity, and manage unnecessary costs in the healthcare system. So we don't create new rules around prior authorization. We use American Medical Association guidelines to set the standards and the medical policies. We have prior authorizations in certain categories. We're a small health plan. We can't PA everything. We have limited resources as well. So we apply prior authorizations for advanced imaging, which is imaging but not, just to be really clear, out of network care. So there's a lot of instances where someone wants to go outside of our provider network for care, and we go through the prior authorization process for that. Laboratory testing, certain medical care, which is a lot of what you were just talking about, and then pharmacy claims. So those are sort of the main buckets of where we do prior authorization. I think you all know this, but emergency medical care is exempt from prior authorization processes. So when we're talking urgent, it's not emergency, it's urgent in a different category. Most of our prior authorizations are done electronically. And if they satisfy the criteria, which I've heard you all talking about, clicking the boxes, we automatically approve them. So to give a little bit of numbers, about 14% of our medical prior authorizations are considered urgent or marked urgent when they're submitted to us. So that's about a little over 5,000 of the 37,000 we processed in 2022.
How much? I'm sorry.
It was 5,246. So 14% of the medical prior authorizations are considered urgent.
Can I have the number of the total? You said again, 30 what?
37,451.
Thank you. Sorry.
I think that'll be in the next Act 152 report that you got the numbers that Sebastian were from the previous year, 2021. And then he gave you this number before, but about 0.5% we just authorized because we run out of time. So if we can't do it in the timeline that is mandated through the statute, we just fit. So I think the other thing I've been asked about to bring to you is how much we estimate is saved across the system annually through our prior authorizations. So we believe in aggregate, we save roughly $30 million. That is net of our cost to administer these programs. It is not net of the provider's costs, clearly.
A year, 30 million a year.
Yeah, explain that. Blue Cross Blue Shield.
We estimate that we save for our members $30 million a year in just these targeted areas: advanced imaging, pharmacy, in some medical and laboratory. And then I have ROI rates. They're different and I don't know if you care about all
Your
this.
what rates?
Return on investment rates, like what we anticipate. So pharmacy is where we save the most for the amount of money that we spend to do the PA. And that's about over 13 to 1 return rate. Advanced imaging, about 10 to 1. In-house medical, so that's the stuff we're doing in our Berlin office, about a little over 3 to 1. And I don't think I got it for laboratory, but laboratory is higher than that. So that a lot has to do with the cost of the service being provided. So clearly, advanced imaging and pharmacy claims are very expensive. So
that's going to be and I know there's other questions, so we'll get to it, I promise. But so when Sebastian showed us the slide from last year's report, that showed.
I tried to print out the report.
The eventual denial rate was small. So you're saying that small percentage saved you $30 million. Okay.
Really?
And then do you have the data on here it is. So do you have the data? So it says, I'm just gonna, okay, so the grand total from this report was 32,181. Do you, and 14.6 was denied. Do you have the data for how long it took those 32,181 to process through your process?
I do not have the answer to that question.
Is it possible to get it for us?
So in average, like number of days or number of hours it took to process it?
Right.
Okay.
Yeah, I mean, we're hearing that, people, yes, there's this timeline of 24 hours for urgent, 2 days otherwise, but we're hearing that some of these go on for a long time. So it would be helpful to understand.
Yeah, I'm happy to ask that and try and get that information. I would say that Blue Cross and Blue Shield of Vermont's policy on something, at least the urgent ones that we can't complete in the time, the 48 hours right now, we just approve. So we don't muck it up. We say we can't do it in that timeline and approve it.
Okay, and then I want to go back to that 30 million. How much of it was pharmacy?
13,
13.
over 13.
Over 13 million. Okay,
So pharmacy is definitely the largest.
okay. Sorry, Leslie and Melanie. And we'll get this in writing, right, eventually.
I don't know if this has been studied, but do you have any idea about negative outcomes or any outcomes that are affected by the prior authorization process? Like the denials, and what happens?
Delay of
Care, yeah.
Yeah, so that's what I've seen the studies on, is if you delay the care for too long, you can have negative consequences. And I think you will hear me say that we're supporting the 24 hours for the urgent here. I do have some requests, but in concept, we think that approving prior authorizations in a time efficient manner is the right way to go.
Melanie?
So forgive me if I'm just feeling a little foggy about this. So how do you calculate that 30 million in that? You said savings for Blue Cross and Blue Shield members? What does that mean? Is it just by not authorizing these, it's just didn't get done, so we kept the money? Or I don't understand how you calculate that.
Yeah, so it's not like an exact science calculation. If it was something that was totally denied, we would say that was money that wasn't spent on that patient's care, so it was saved. So it's money we didn't spend.
So not having care saved money.
Not having inappropriate care saved money.
So it was deemed inappropriate.
Yeah, not medically necessary.
Across Blue Shield's perspective.
From our perspective.
That was where I was getting to.
Absolutely. Then there's more nuance to that. That's like the easy calculation. There could be, they had a different treatment as a result of that denial. They went to a different kind of care. They had a lower cost care. Those types of things could have happened. So then the savings is less because we've got to figure out the difference.
Do we know do you have those numbers? Like how that, I mean, if you don't have it right now, I just would be curious as what was went to other care, what was inappropriate?
I didn't ask for that level of breakout, and I do think they're pretty rough estimates. Again, it's not an exact science how we calculate it. And then we netted out our costs to administer the program.
Art, sorry.
Sarah, is it 30 million in savings just in Vermont or nationwide?
Just in Vermont. We're just Blue Cross and Blue Shield of Vermont.
Okay.
We're only talking about,
So just Vermont.
yeah, it's
Okay.
about the 220,000 people that we cover.
And this is per year?
Yes.
Okay, thank you.
So I'm wondering if you keep data on patients who had a denied prior authorization, who then at a later date have another prior authorization submitted for the same service that is eventually approved. And if I can just, I don't want to testify myself. However, I know, particularly with advanced imaging, that one of the requirements sometimes is that somebody go through a course of physical therapy before that advanced imaging is. And I know also that Blue Cross Blue Shield's spend on physical therapy is increasing a little bit. I believe I've heard those numbers. And I'm wondering if an original denial and then the step that you make someone go through to eventually receive the care that was ordered in the first place, if you're calculating that in, and if you're keeping data on how often prior approval is then put in for the same original service, that if it had been approved, they wouldn't have had to go through those steps.
Yeah, good question. I have been asked that in the past. And I think to nuance the answer a little bit, we're looking within a calendar year. So one thing that I know that I'm not capturing here is say you had to go through physical therapy in 2022 and then you got your your MRI in 23. We wouldn't capture that because we're always looking at one calendar year, which isn't ideal. I can ask about the other. I think we are trying to, if we've asked you to do physical therapy first, and then we're saying that that is done instead of the advanced imaging, we're netting that against the cost of the image.
Are you, as it pertains to prescription drugs, are you calculating the savings by not paying that one drug, but are you then including the cost of the drug, the substitute drug? And then also to the same question, did they eventually fail on the substitute drug and then go on to the more expensive drug that you had originally denied?
Right, good question. That one, so Optum calculates that for us, and I don't know how detailed they get into that, but let me ask. I would again assume that once it crosses the calendar year, that we're not capturing it in the yearly sort of look. You know, it's a snapshot. It's not a longitudinal study.
And last question, I'm wondering just what the administrative cost between, in-house Blue Cross Blue Shield, what do you use, Evacor, I think? Imaging, the administrative costs to, what is the total for all prior authorization?
Yeah, so I do have it. We use for advanced imaging, we use a company called Carillon. For our laboratory, we use one called Avalon. We use one, I'm doing quick math here, for our internal and then of course, pharmacy is done by Optum largely. So it's about $3.7 million is our cost annually.
Annually?
Yep. And that's netted out of the 30 million that I told you we save.
So I just want to go back to the 30 million, and I'm hoping you can provide in writing, I don't need it now, the breakout of the different categories that you do prioritization, what the cost is for those. And I also just want to, correct me if I'm wrong, but the 30 million is a bit squishy because you may or may not be capturing if someone is denied for something here, but gets a different service over here. So you're saving the fact that someone isn't getting an MRI, but then they go over here and they get CT scan. I know that doesn't make sense because they show two different things, but so it's a little squishy. Okay. Leslie, and then we need to move on a little bit. Or Art, someone had a question.
I did. So I'm looking at the report from November of 23, that report. And
Okay.
there was talk about expanding gold card and the pilots, but we heard that the gold card, since it's not across the whole system, that the whole work was getting done anyway. So they weren't that valuable. People didn't sign up according to this to get involved. So can you talk more about that and where you are with that process of streamlining, simplifying, all that?
Absolutely. That's where I want to go. So just maybe two other points I'd like to make on the topics here, and then I'm going to jump right there. Our average, I'm going to call it denial rate per provider, impact rate per provider is about 8% across the board. That's an average. I talked a little bit about what an urgent PA and what percentage of our medical PAs are urgent, so about 14. So we use the NCQA criteria for what is urgent, so I can be a little more specific. It's a request for a medical care or service where the application of the time frame for making routine or non-life-threatening determinations could seriously jeopardize the life or health of the member or their ability to regain maximum function. And then there's a lot more to it, but that's generally it. We do see some providers click the urgent box for things that are clearly not urgent. I think the example that I was given was a PA for anesthesia for a colonoscopy or something like that, that's not scheduled for a month. So the only thing I think we would have to do when we have this shorter turnaround time is pay a little bit more attention to what's being considered urgent and make sure it truly meets that criteria. But I think what we want to do is say, if the doctor says it's urgent, it's urgent. Let's, do it quickly. So let me jump to what we've done recently with our gold carding program, as well as other removals of prior authorization. So we began that gold carding program in 2020, just as COVID hit. So the timing was not great. And I would say that the first 2 years worth of data are not particularly helpful when we're evaluating the program. So I think you'll see in the report, we were pulling the most latest data to try and see what happened. And I think we acknowledged that it was an experiment, a pilot. It was called a pilot in the report to see if we could ease some of the burden on our providers by doing this. We found that it wasn't a perfect system for all the reasons you heard from these providers, that it's very hard for us to gold card an entire institution. So if we gold card an entire hospital, every single provider in that hospital, whether they, are following the guidelines we want them to or not, would get that PA, but we realize it's also complicated for them. Some of the feedback we got, because we actually did a survey of providers, were, we don't know what Blue Cross is doing compared to what the other, ones are doing. It's too hard for us to keep up with it. So we just do the PA anyway. So I think we haven't eliminated that program. We've tried to expand it in certain areas, but we recognize that there's problems with it. And so we've been trying to look at more creative ways to deal with PA. So a couple of things that we have done, and this would start with Dr. Weigel, who came in here and testified the other week. He is a mental health specialist, and he really focused on that aspect of our prior authorizations. So since January 23, we've removed prior authorizations for, and I have to read it so I don't get it wrong, in-state, in-network mental health and substance use treatment for the following levels of care: inpatient, residential, partial hospital, and intensive outpatient treatment. So he felt like they were not necessary in that category. As a system, we're seeing lots of problems with access to care. And he didn't feel that our process was adding any value there at all. So we just removed them. Let's see. And I think that, focusing on in-state, in-network was a way to also keep the costs. We work with these facilities. They're in our backyard. These are providers we talk to all the time. And so we feel like the decisions they're making make a lot of sense. We still have it for out of network and out of state. Another one that I'm very happy to announce now and will be publicly announced, it's no secret though, next week, is that we are removing prior authorization for MRIs if they happen at Open MRI, which is a facility both in Williston and in, I don't know if it's called New Hampshire Open MRI. I think is that where it is? Okay, thank you. So the reason that we're doing this approach is that we think it's simpler. We know that if someone just wants to get their MRI and not fill out any paperwork for it at all, our patients can go there. They still need a referral from their doctor. It still needs to be medically necessary. But the other reason we chose MRI, Open MRI, is that they have recently upgraded their technology, their MRI machine. It's the sort of most advanced one out there. And so we expect we won't hear complaints from providers that it's somehow a substandard MRI. We did it also for convenience. They have longer hours than most facilities. They are open till 6 or 7 at night. They're open on Saturdays. They have more appointments. So the idea was to facilitate easier access to care. And the last reason is that they're about a quarter of the price of most other facilities in the state. So that's a significant factor, but it's a big factor. So we know that if you go there for your MRI, it just costs a lot less.
It's better for patients too, right? Some people get, pretty claustrophobic, but anyway.
Yeah, there's a lot about it that's cool.
So we're not gonna go into that, sorry.
It's probably not the perfect solution, but it's like a thinking outside of the box solution. How can we do this in a different way? So, then, ones that are coming up, we're looking right now at home health. We believe that our home health denial rate is very low. We typically work with the local home health agencies, and believe that we don't want to be a barrier to care in that area as well. So those are coming off. I know you don't believe it, maybe, but it does take some time for us to go through all the process to make these things happen. We have to notify all the providers. We have to make arrangements. So it's coming, but that one we expect to be done. And then there is a list by CPT code of all the ones we've added and all the ones we've, removed. I wasn't going to go through all those because I couldn't explain them all.
So,
You want to talk about the bill?
yeah, I was gonna say,
Okay.
But I'm not looking at primary care. Are you looking at primary care? Folks? Sorry, but
So, yeah.
you
so-
can tell me.
I think what we're gonna need to do is,
Sorry.
no, it's, we think we're gonna have more time than we have in the mornings, and this is all good testimony. I think what I would like to do is have a couple more questions asked, and then I think what we're gonna need to do is schedule time for, you to come back and tell us what you like or don't like about the bill.
Okay.
Like quickly, I mean, in the next day or two, or if it's quick.
I think I could be very quick on
Let's
this.
do that first, and then we'll see if we have time for questions. Let's do that.
Sure. I'll try and be as quick as possible. And I'm focusing only on these
Fire up.
PA Section 3 and Section 4. Just so you all know, when we get to step therapy, I have Nancy
Yeah.
who can speak.
We'll make sure we have plenty of time for that.
So, like I said, we worked with the whole group this summer. We agree that speeding up this process is good. What Blue Cross and Blue Shield of Vermont would really like is more time. We are adopting Blue Cross and Blue Shield of Michigan's IT systems and trying to bring them to here. We believe it will significantly help us speed this up, but we don't think we can do it for January 1st next year. So we would love
The effective-
January 1st, 26 instead of 25. So that's the biggest, most important part of my request.
Okay.
Then to talk about the last, I think it's page 11, but I have the little printout version, so I don't know if it lines up with yours, but Section 3E, that says for an insured who is stable on treatment, service, or course of medication is,
I'm sorry, can you tell me again where we are?
I think it's page 11.
Okay.
It's Section 3E,
Okay.
big E.
Oh, right, so row
And
19.
it's the last one before Section 4. That was approved for coverage under a previous health plan. A health plan shall not restrict coverage of that treatment, service, or course of medication for at least 90 days upon the insured's enrollment in a new plan. I don't know if Sebastian is still here. We already have continuity of care requirements. If someone's under a course of treatment, then they get time. What we're worried about is the 90 days for every single thing. What that does is just push out for a quarter of the year when they have to seek a prior authorization with Blue Cross and Blue Shield of Vermont for something that another health plan in the previous year.
Right, and I think the intent is to give the time for that to happen, rather than they switch plans and automatically are maybe taken off something.
Right. We could talk about it. I wanted to look up what the current continuity of care requires, but, just giving an automatic 90 days is 90, a third of the year of potentially higher costs, or delaying the inevitable. I'm not sure it solves the problem, but
Okay, so if you can look at continuity of
let
care,
me look that up.
I feel pretty strongly that if someone's switching a plan, they should not be off of their medication that they have or treatment that they have. So if you can also talk about how that's handled within your organization now at a later date, that would be great.
Sure. And then the last are Section 4, which this is the DFR rulemaking and guidance bulletins around prior authorization. So whomever gets assigned this work. Our concerns are about, when you say any generic medication, I know the assumption is that generic medications are less expensive. There are some extraordinarily high cost generics. And so I think we don't want to pull out every generic. And then the other thing is the 10% across carriers. We're worried about statistically low volume services that had extraordinarily high prices. So only a handful of patients seek those services, but the costs are millions of dollars. So
What would you suggest in its place?
maybe we could add a dollar threshold, or I hate putting stuff like that in law because then, in 10 years, we'll all wonder what we did. But
Okay.
I think because it's in its rulemaking, we could say high value or something and not put a dollar, and then DFR could make the determination of what high. Do you know what I mean?
Yeah.
And I would want it to be statistically significant. So those are the requests I have.
Okay. So thank you. We're going to probably have to come back to this. And again, I apologize. I do have one question.
Sure.
On the 30 million
Mhm.
that you're saving, what is the dollar amount to a QHP premium? And have you actually reduced premiums because of these cost savings?
Right. So I'm going to answer that question in the way that our actuary answers that question every time I ask her. So what we do is we don't calculate your premium and then say, oh, we're saving 30 million because of prior authorizations and reduce it. We look, our actuaries, not me, look at the trends over time in usage and cost of services. And so it's built in the underlying assumptions about what care will cost next year based on in the previous year.
So have your actuaries looked at this bill and determined what a cost increase to a premium would be if we pass this legislation?
So this bill, the changes in the time frame, again, we support. I think when I talk to our pharmacy people, we largely meet those timeframes. The area that we're concerned about is the medical pieces. And so we don't think the impact on the cost is enormous for this bill.
Okay. If it's very fast, no, it's very fast.
The 37,451, what year is that?
I think it's 22. So what he was showing you is 20.
Just half the number.
Okay, can we?
Yeah, I'll ask you later.
Okay, great. Thank you, Sarah.
Thank you.
Jordan, thanks for being on Zoom.
Can you see me all right?
But we see a black screen, but we can hear you. It's not.
Hold on. Let me,
Let you have the lights out.
there we
Great,
go.
there you are. Welcome back, Jordan.
Yeah, thank you for having me. And I can be very brief. I certainly don't want to waste the committee's time reiterating a lot of the same points that Sarah made. But for the record, my name is Jordan Esty. I'm Senior Director of Government Affairs at MVP. And, thank you all for the opportunity to testify today. So at the outset, very brief, I'd like to just offer a few comments on MVP's view of prior authorization programs. And I would say we share your concerns about unnecessary complexity and the administrative burden in healthcare. The system is too complex, it is too costly. And we want our members to get or access the necessary care that improves their health and quality of life. Creating unnecessary burdens or hurdles that result in care denials, as have been discussed this morning, those things don't benefit MVP either, right? So when our members have a bad customer experience, they're more likely to switch health insurers. We lose their business. When our provider partners have a bad experience, it causes reputational damage in the local community and really strains what are critical partnerships that we feel we need to best serve our members. So another important point I think that has also been kind of hinted at or discussed this morning is that prior authorization policies cost MVP at the end of the day, right? They require staff to review requests and maintain policies. We have to make additional investments and resources to support internal and external appeals when those the volume of those things go up. We have to make IT and other system changes and configurations. So at the end of the day, the higher our administrative costs are, the more expensive our premiums are, and the less competitive we are in the market, again, which results in membership losses. So from our perspective, crafting, reviewing, and maintaining prior authorization policies, it's a very delicate balance. When we establish a new policy or we choose to continue a policy, we feel there has to be a very significant return on investment for every dollar that administering the policy costs MVP, or there has to be very clear safety, quality, efficacy reasons for doing so. There was a couple of comments about how we calculate that return on investment and whether the cost of alternative treatments is included in that return on investment calculation. My understanding is MVP does take a look at that. So when we're assessing ROI, we are netting out what the cost of alternative treatments are. To that end, everything I've mentioned here, we have removed a long list of prior authorization policies in recent years, and we really try to be thoughtful and collaborative when we're establishing new policies, recognizing all of the things I've just discussed and all of the things that have been raised this morning. We also try to be mindful about what we're asking of providers. So, when we think about the turnaround times, part of that challenge, if you will, or the mechanics of how that works is there's certain information we need to process the claim. And, we're very mindful of what we're asking for providers to submit and really seeking the minimum necessary information we need in order to make a decision. I think that helps us speed things out. And then lastly, I would just point out automation, innovation around data sharing and integration presents real opportunities going forward to continually lessen the administrative complexity and the costs that are in the system today. So something that we are invested in, excited about, and kind of always looking at ways to kind of improve the process for our members and our provider partners. So on the bill itself, a few points. MVP is largely supportive of both the prior authorization and step therapy provisions in the bill. Section 3 dealing with the turnaround time for decisions on urgent requests like Blue Cross Blue Shield, we support this. No objections to this change, as we're already subject to a 24-hour standard on drug coverage in Vermont, so we don't see this as a significant issue for MVP.
Okay.
Section 3 regarding the duration of any prior authorization, as proposed, it was specifically require that those authorizations be valid for the duration of a prescribed or ordered course of treatment or 1 year, whichever is longer. MVP honors decisions today for a year. So that's not going to be an issue for us. A technical comment here we would offer is to strike whichever is longer and align the authorization timeline to the standards of care for a particular course of treatment. My understanding, there's treatments where it's not clinically appropriate to continue beyond a limited period of time, like antibiotics or hepatitis C treatments. We wouldn't want to authorize something for an extended period of time when the standard course of treatment or care does not support that.
Okay.
On Section 3 about the coordination of approved treatments when a member switches health insurers, we absolutely agree. Continuity of care, transition of care is critical. The mechanics of how this is operationalized in the most efficient and meaningful way, I think, will require more detailed discussion, but something conceptually we support. What we want to avoid is any overly complex process around coordinating these transitions that unintentionally has more burden for providers and members, right? So, we're going to need information in the medical notes or in a data feed of some sort that indicates that a member has received an authorization for a certain service, right? And they would want to continue that with the plan, the new plan. And then on the 90-day component that Sarah raised, I think, we would welcome further discussion on that proposal. Maybe a different way to frame it is up to 90 days instead of at least 90 days. So that's giving us a window of time in which to complete the transition, but not just applying I don't want to say arbitrary, but a standard number that may have unintended consequences.
Okay.
Section 4 regarding the DFR regulatory guidance on prohibiting prior authorization for any generic medications or any service that has low variation across providers and denial rates of less than 10% across carriers. We do not prior auth generic medications that are covered in our formulary today. They may be on a different tier depending on the cost, but we're not requiring prior auth for generic medications. We too have concerns about the 10% standard for all the reasons that Sarah articulated. The volume of services varies. It's going to vary across carriers. For policies involving extremely high cost drugs or treatments for rare conditions, the volume will always be low and it's not going to be statistically significant. We may get 1 or 2 requests for something like gene therapy for hemophilia or CAR T for oncology in a year, we may get none in a given year. So, and there may be quality or safety reasons for requiring certain authorizations regardless of the volume of those services. So we would welcome a more, a different approach on how we're quantifying potentially through regulation what needs to be subject to the standard. I'm sorry, was there a question? I have one more comment.
Yeah, no, you're good.
I throw.
You're good. Keep going.
Yeah. So on step therapy, under section 1, our reading.
You know what, Jordan? I'm actually we unfortunately are not gonna have time for the step therapy conversation because we haven't really even discussed that, what it is as a committee. So if we can hold that, that would be great.
Okay, well, that concludes my comments on the bill or these sections of the bill. So welcome.
Okay, great. So one, I'm hoping we can get that in writing, and then I'm gonna look to both Blue Cross Blue Shield MVP on the section 4, if you, or any of the sections, if you have suggested language, please send that to us. And then we can have a further discussion with everyone. That would be great.
Glad to do that.
Great. Art?
We might want to address the effective date.
Yes. Did you have a concern with the effective date?
I don't have one at this point.
Okay.
I think, I'd want to have more conversations internally around the turnaround time component.
Okay.
Is that what you're referencing?
Yeah.
I will certainly put that in writing if that is a concern.
Okay.
But right
And
now,
then
we're doing this anyway because of the prescription drug turnaround time, and the notification component under current statute requires us to respond to a request within 24 hours. We have 48 hours to issue it. In MVP's experience, we've had difficulty operationalizing, my understanding, the notification. So we end up actually having to do, a faster turnaround than 48 hours on a lot of requests anyway.
Okay.
But instead of just sending a notice, then coming back, we're doing it all at once, is my understanding.
Okay. Great. So thank you very much. We will, we're going to come back to the other 2 sections of the bill, I think next week. We're still working on the schedule, but so this, we'll have time to get your input on all the sections, but your language on this, and then we'll reconvene the conversation. So thank you, Jordan.
Thank you so much.
So we want to, and I know Diva's still on the line, but I want to switch back to the 2 providers we have on the line. So why don't we go to Mark Peluso? Did I say that right, Mark?
Hi, yes, thank you.
Hi, welcome. Can you introduce yourself for the record and then provide your testimony would be great.
Thank you. Yes, I'm Mark Peluso. I am a board certified physician in both family and sports medicine. I've practiced in Vermont for over 20 years, and I'm currently the chief health officer and college physician at Middlebury College. I think it's important for the committee to know that I don't bill patients or insurers and have really no financial incentives around patient volume or procedures or reimbursement. My salary is fully salary-based. And you should also know that I served for 2 years on the Green Mountain Care Board Primary Care Advisory Group. And we my term ended in 2018 with recommendations regarding prior authorization. And we recommended to eliminate prior authorizations in favor of patient and provider education. I did submit those recommendations early as part of this testimony, and won't be going into a lot of detail on that. I would also let you know that I would say 100%, if not 99.9999% of all my prior authorizations get approved for my patients, ultimately get approved without fail. But they continue to delay care and waste a lot of time. I have stopped in my practice. I refuse to participate in peer-to-peer review. That's a prior authorization tool where prior authorization gets denied and has to go to medical review, and then I have to call and go through a phone tree and eventually talk to someone. In my experience, I end up talking to people that either aren't physicians or initially, or don't understand the specialty I'm dealing with, sports medicine specifically. And by the time I get to someone that does, it gets approved within 30 seconds. But the time it takes to get there is ridiculous. I will take their calls if they call me, but I won't go on hold or do phone trees or hangups. Some examples I want to share with you are a patient that had a bleeding ulcer and almost died from their ulcer. And those patients should never go on anti-inflammatory medications, the standard anti-inflammatory medications like ibuprofen. This patient had hip pain. They were going to a national championship match and needed some, I diagnosed them with a tendon issue and wanted some pain relief. Tylenol wasn't cutting it. Celebrex is a medication that is a non-steroidal anti-inflammatory medication that significantly lowers the risk of bleeding ulcers. This should have been a slam dunk prescription, but instead it required a prior auth. I was desperate to try to get this patient medication before they left, and went through hours of trying to get through an electronic prior auth, a phone prior auth, and the system ultimately failed. The patient left without the prescription. They came back from their tournament. I asked them how they got through it, and they said they used some medications they didn't want to tell me about, and that's narcotics. They use someone else's narcotics, which we don't want to do that.
Right.
The interesting thing here is, and I should say, I'm telling you these stories. I'm not. I think we all share common ground. The insurance providers, everyone in the room, obviously, we're all trying to take care of people, right? We're all trying to help people, and I don't mean to insinuate otherwise. But in this case, the insurance company paid for 2 procedures to stop bleeding ulcers that almost killed this patient. It should have been a slam dunk prior for Celebrex, and it wasn't. So that's a system issue, but it's a good example. Another one is another patient with hip pain. We needed to rule out a stress fracture in their femur, which, if that breaks, that can be devastating, life altering. And they were going to a championship. And if the MRI is negative, we can't diagnose that with an X-ray. We need an MRI for that. We can get an MRI, but we couldn't get it authorized. So we had an appointment set up, but we couldn't get the authorization. So that student went to the emergency room and got the MRI through the emergency room, which incurred systemic costs for emergency room visits. Plus it filled up, took an ER slot, which our ERs are busier than ever. So we don't like to do that, but sometimes that's done, and that increased costs. And the last example is a patient that had their medication changed on them. They go into the pharmacy to pick up their prescription. They didn't know that the formulary had changed. They needed a prior auth for their medication. They didn't take it. They didn't call. This patient wasn't very well educated, and just thought, oh, I guess I can't afford my medication anymore. They decompensated, ended up in an ICU, and all the costs associated with that. They survived, but it costs a lot of money. I will just finish by saying that the prior authorizations, I think, are having a significant impact on the medical profession. It's no surprise that, or I guess it is a surprise that physician suicide rate is twice that of the general population. I think it's the highest suicide rate of all professions. That there's evidence and references about 20% of physicians are going to reduce clinical hours in the next year. 1 in 50 intend to quit altogether. And that has a cost to it. There's one estimate of it's $25,000 per physician to replace those physicians. And if you try to get a primary care appointment in Vermont right now, you're looking at a 6 to 9 month wait, unless you have some condition that bumps you to the front of the line. But for just about everyone, it's 6 to 9 months to get a primary care appointment. So we've got physicians that are burning out or struggling because of all this administrative burden. That's well documented in a lot of the references I've provided. We're just tired and fed up with having to fight over and over and over again for our patients, and either want to reduce hours or quit. It's hard to recruit. I've talked to the UVM Health Network folks about trying to get some of the Middlebury College employees primary care access, and they're doing their best, but they're really struggling to recruit providers. I think every minute we're spending doing prior authorization is increasing frustration and decreasing time when I could be treating patients. And when I have to deal with a prior authorization on short notice, my clinic schedule doesn't change for that. And I have to all of a sudden catch up in clinic, which means I'm spending less time with the patients that were scheduled that day. I don't think that's good for patient care. So I think there's a lot of hidden costs that the proponents of prior authorizations can't really calculate and include in their assessments on their return of investment assessments. I also I think, you know, if it's 30 million, I just heard the number 30 million for 220,000 participants, that's $11 a month in a fee increase. As a physician who gets all of their prior auths ultimately approved, to charge someone $10 a month more so I can spend more time with them, see more patients, and be less frustrated and do a better job and maybe stay in the career a lot longer, that seems like a small price to pay. The 2017 Green Mountain Care Board Vermont Clinician Landscape Study said administrative burden is the greatest risk, both for employed and independent physicians. So I guess I'll end by saying, wouldn't it be great if we could just increase care access by replacing administrative tasks that really get approved anyway, and just be able to see more patients. And I think there's an opportunity here to make Vermont one of the best places to practice medicine. We could actually use it as a recruiting tool if we could get rid of prior authorizations across the board. I think there's a better way to do it. The Green Mountain Care Board Primary Care Advisory Group in 2018 recommended transitioning away from prior authorizations to a more educational platform of let's educate physicians and consumers and about what we should be doing, and then you know, but leave it up to the doctor and the patient about what's best for that person. Thanks.
Great. Thank you so much, Mark. One, for waiting all this morning with us and for providing your testimony. And I will say there's quite a bit in his written testimony that he did not cover today. So I encourage everyone to read it. I think in interest of time, Mark, we're going to move over to Rick Dooley. Thank you very much. Hi, Rick. Thanks for hanging on here with us.
No worries. Thank you so much. So I'd just like to thank the House Healthcare Committee for this opportunity to address you. My name is Rick Dooley. I'm a full-time family practice PA at Thomas Chittenden Health Center in Williston. And in addition, I'm also the Clinical Network Director for Health First, which is an independent practice association representing primary care and specialty practices across the state. So I was seeing patients this morning, so I'm not sure exactly what's been said already today, other than Dr. Peluso's statement that I just heard, that I fully agree with his assessment of the administrative burden in primary care today. So I'd like to share with you just some of the negative impacts that the current prior auth process has had on my practice, just to give you a sort of boots on the ground view. So we're a pretty large independent family practice. We have 13,000 patients. We have about 12 full-time equivalent PCPs. We have some associated clinical staff, and nutritionists, social workers, some psychiatry nurse practitioners, care coordinators, and such. And then a full slate of clinical and non-clinical staff. In fact, we have 1 clinical and 2 non-clinical staff for every FTE primary care provider. So we have 3 staff for every provider. Some of our other Health First practices.
Wait, can we just say that again? I'm sorry. You have 3.
We have 3 staff members for every 1 full-time equivalent primary care provider.
Thank you.
Some of our Health First practices have as much as 4 or 4.3 staff members for every PCP. The need for the expansive staff is twofold. 1, it requires a significant amount of clinical staff just to provide the growing number of services, both medical and social, that are expected from primary care. And 2, the administrative requirements around prior authorizations, billing, payment processing, insurance audits, reporting, and such are very onerous and time-consuming, and sadly labor-intensive. The burden of prior authorizations for medication is crushing to our practice. Hours and hours of staff and provider time are spent completing online forms, combing charts to provide dates of previous trials and failures, and writing out justification for why medications should continue to be covered. It's not unusual for a nurse or medical assistant to spend up to 45 minutes to an hour on hold on the phone just trying to get a single prior authorization. My nurse personally spends approximately 2 to 3 hours of her 10-hour day working on prior authorizations in between rooming patients and taking calls. Coincidentally, as I give my testimony today, we've just started a new calendar year, and with it comes the need to reauthorize medications that were authorized perhaps the previous 12 months. The start of the year also brings formulary changes, meaning the medication that a patient has been on for several years may now be considered non-formulary, requiring a higher copay or a trial of a different medication. Patients often react differently to different medications, even within the same class, so any change requires more follow-up either by phone or in-office visits, just decreasing access for other patients. In addition, sometimes formulary changes actually result in an entire class of medication being excluded, resulting in a need to trial a medication that may not be the most appropriate one for that patient. The end result is a tremendous amount of primary care resources expended so that a medication that is less expensive to the insurer, but potentially less appropriate for the patient, can be prescribed at least for the next 12 months or until the next formulary change. The problems are exacerbated when there's supply chain issues, and you've probably heard about the difficulties lately with stimulant medications like Adderall. Because the supply of generic Adderall, amphetamine, dextroamphetamine, is in short supply, practices initially were required to switch to brand name Adderall, all of which required prior authorizations for the brand name. Sometimes insurers said they wouldn't cover the brand name, but they would cover a different generic stimulant, which is not necessarily interchangeable, but so we would try to switch to a different stimulant. As the supply chain issues sort of spread across the class, we would find that frequently we'd send in a prescription for the preferred drug to find it required a prior authorization. We do that prior authorization. By the time the prior auth got completed and the patient returns to the pharmacy, that drug is no longer available. And then we need to find either another pharmacy or another drug, and we'd try another prior authorization. The cycle would continue. With regard to prior authorizations for imaging or treatments, there are multiple points of frustration, and I'm glad to see that H766 does address some of these. My office, with 12 providers, actually has 2 full-time referral specialists responsible for prior authorizations prior to scheduling imaging and specialty consults. One common issue they report is the time frame around approvals. Oftentimes, an imaging or treatment facility won't schedule the appointment until they have the prior auth in hand. The prior authorization comes through specific for a facility as well as a time frame or an expiration date. When we then go to schedule the patient to get the imaging or specialty appointment, it falls outside that time frame. So they then need to redo the prior authorization a second time. If in the meantime we find that there's another facility that can better accommodate the patient, we again need to reauthorize the prior authorization for the other facility. Now, while these reauthorizations aren't as time-consuming as the original request, they are nonetheless a cause for increased administrative work and time in each office. My last point with prior authorizations, and this is made by Dr. Caluso as well, is that almost all the time, 99% of the time, my prior authorizations are approved. If I'm ordering a medication for a patient, I can generally justify its need. If I'm ordering an imaging study, it's generally because it is the medically appropriate and necessary step. So the issue is not that these items are not getting approved. The issue is the time and effort that we're dedicating, including staff and provider time, to comb through charts, complete forms, schedule peer-to-peer reviews, and write letters of justification. And I would agree with Dr. Caluso that the time that my office is spending and that I'm spending as a provider is not included in the ROIs. Prior authorizations are certainly not the only administrative burden, and I harbor no illusion that H766 will eliminate all the primary care woes we're facing. However, I do believe that a strong foundation in primary care is essential to improving patient outcomes and reducing system cost. We can't provide that strong foundation if we don't have providers willing to join our ranks. Any effort to reduce the burden on primary care providers is welcome, and prior authorization is a great place to start. Again, thanks for your attention to this issue.
Great. Thank you so much again for what you do for Vermonters, for hanging with us all day and providing that great testimony. The last thing you said, I think, is so interesting because we hadn't heard that, but I think is really important, is this imaging, prior auth, scheduling, and with our access problems right now, I can see that being an issue where you're having to go back and get a prior auth. So I appreciate that. I'm gonna throw out a question for everyone that I don't really want answered right now, but everyone keeps saying that most of their prior auths are eventually approved. So do we have statistics that categorize the prior auths that are not approved? Can we look at this a different way to figure out what we can keep and get rid of? So again, just something for people to think about, and then maybe, and then Rick or Mark, I don't know if you want to say something now, but can, think about it. If there's any comments, get back to us. Okay, great. Thank you. So we are going to hear from, oh, sorry, go ahead.
This is to piggyback on a question I had a while ago when Sarah was talking. I think you were giving some statistics around the denial rate per provider. Was it 8%? Something like that. To follow up on Lori's question around categorization of denials, I'm curious if you could give us some of those statistics in the range of like per 1,000 submitted. So just some more general categories so that we can look at it across the system versus at an individual provider rate.
Mark, I saw you pop back up. I didn't know if you wanted to say something.
I was just, I thought there was a question directed to Rick and I about, but I think you said hold off on answering it.
Unless you have a quick answer now, that would be great.
I'm 100%. Everything I get gets approved.
Okay,
It's easy to state that.
that's easy to state that. Yes, thank you.
Could we ask how many times you have to resubmit to get that approval?
It depends on the insurer. My population,
We just lost you.
You're freezing.
From Middlebury?
Well,
All
because
right, well,
you're-
we can reach out to him to get.
Well, that's sort of a question, you get 100%, but you still had to do it 4 times.
Right, and we asked the payers for that information as well. Rick?
I just want to add that also the approval, it is not just a matter of submitting the form and getting it back. Like you said, it's the extra work of the peer-to-peer. If it goes to a peer-to-peer, meaning I actually speak with the provider at the insurer, I would say my rate is probably 100% too, and I think most of ours are at that rate. Also, if it gets denied initially, I would be curious to see from the insurers how often the study or the medication ends up being required 3 or 6 months down the road after the first trial has failed.
Great, thank you both. Mark, you cut off. We lost you, but I think you were saying 100% get approved eventually.
eventually,
And then, like how many times average do you think you're having to resubmit to get to that eventual approval?
it varies depending on the insurer. And we have, with our patient population, we've got out-of-state insurers paying for some things in Vermont. So it's not necessarily the Vermont insurance group, but I can say that it sometimes takes a couple of rounds to get just standard imaging done. And I don't understand why we submit the same note, because I document now. I spend time documenting, knowing that it's going to get going to need a prior approval. I try to avoid I try to tee it all up at the first round. Sometimes they just resubmit it. Eventually it gets approved. It can sometimes take 2 or 3 rounds. I had one insurance company denied a prior approval for an MRI. It was a standard MRI for a knee. I did the peer-to-peer and they said, well, you didn't put the right code in. I said, well, what's the right code? This patient, I'm the doctor, I've talked to you about why the note clearly describes what the injury is and why we need an MRI. And they said, well, I can't give you the right code. You're going to have to figure that out for yourself.
Okay,
Been there.
frustrating. Thank you.
Yeah.
Sandy and Alex, I'm sorry. Hi, Sandy. Did you have anything quick to say, or can we have you back?
I can really quick just address.
You know what, hold on, Sandy, you're echoing.
Still?
Yes. Do you have us on in two spots?
I don't. Am I still?
Yeah. Like you're-
Alex, you don't. No. Are you listening to me on your phone?
Sounds like Neil Diamond.
Right, it does sound like Neil Diamond. All right, Sandy, I think what we're gonna need to do is have you back, and then you will go first, I promise. All right, thank you. So we obviously have a lot to come back to on this, but I think it's good first to start the process, and we will continue it. And now we will go to lunch, and we are back at 1:15.